ICU, and this class is for the IDCCN candidates. I'm Dr. Pralay. I am presently working as consultant in critical care at Tata Medical Center, Kolkata. This is a cancer hospital. And the moderator of today's class is Dr. Sudipto Mukherjee. He is actually busy in seeing on patient, ICU environment. So he will join after some time. So I expect a lot of communications from your side because I have some open-ended and some MCQ-based questions during my presentation. So during these next few slides, I will be discussing on indications of different drugs which we use in ICU and the preferable routes, usual doses and rate of giving the drug. How does the drugs work in different scenarios, different drugs? And do we need to modify the dose in specific situations like impaired metabolism or impaired excretion and usual side effects of different drugs? So as you know, the most common drugs which we use are inotropes and vasopressors, electrolytes, nebulization, different antibiotics, and sedative narcotics. So during these next slides, I will discuss among these drugs only. I will start with case scenario. I think this type of case scenario is common in ICU wherever you work. So a 65-year-old male patient who had a previous history of hypertension and COPD, chronic obstructive pulmonary disease, he is admitted to your ICU with respiratory distress, and on examination, you found that patient is having bronchospasm. The patient got intubated because of respiratory distress, and we found that patient is having a blood pressure of 190 by 110, and these are the medicines which the patient was prescribed: injection midazolam, injection fentanyl, atracurium, and meropenem, nebulized salbutamol, injection labetalol, and injection pantoprazole. So my first question to the participants is, fentanyl is which group of drug? May I expect answer like 1, 2, 3, 4 in the chat box, please? Please post your answer in the chat box as 1, 2, 3, 4. Fentanyl is which group of drug? So I can see answer as 1. Yeah, so most of the answers are 1, but actually fentanyl is used as analgesic. So you can easily find this as a prescription in post-surgical patients who is having pain. So fentanyl is a narcotic and it acts as analgesic. It has very minimal effect of sedation, but in high dose it can cause sedation, but its main use is analgesia. Fine. So we'll move to our next question. Next, discussion on sedatives and analgesics. The examples of sedatives are mainly propofol, midazolam, ketamine, and analgesics which we use in ICU are fentanyl, morphine, paracetamol, dexmedetomidine, ketamine. In ICU situation, we prefer IV route. If you give any medicines in excessive dose, it can cause hypotension and respiratory depression, and you have to take care of the metabolism of these drugs. Suppose you are giving midazolam and paracetamol, then the patient, if he has a liver failure, then these drugs can be accumulative and can cause side effects. Now the same patient, we have prescribed labetalol. What is the role of labetalol here? So I am answering this. We have used this labetalol as a treatment for hypertension. But can you tell me what is the side effect of labetalol? Is it 1, 2, 3, 4? Hypertension, drowsiness, hypokalemia, and bronchospasm. May I expect some answers in the chat box as 1, 2, 3, 4? Which one is the side effect of labetalol? So I mentioned that we are using labetalol as a treatment plan for hypertension. What may be the side effect? Anyone? So I see that most of you answered as bronchospasm. Yes. So the side effect of beta blockers, labetalol is a beta blocker drug, is bronchospasm. So probably use of labetalol in our patient who is having COPD and active bronchospasm is not the right choice in this situation. Thank you so much. So I'll move to next slide. So for very high blood pressure or patient with high blood pressure and organ failure like heart failure, we prefer IV route. The drug of choice are either labetalol and NTG, nitroglycerin, and if you use in excessive dose, it can cause hypotension. And if you use labetalol as treatment medicine, then side effect is bronchospasm. But if a patient is having high blood pressure but not in emergency situation, then oral route is usually preferred. And the usual medicines are amlodipine, telmisartan, and metoprolol. Again, in excessive dose, it can cause hypotension. Telmisartan can cause hyperkalemia, and beta blocker metoprolol can cause bronchospasm. Now, this same patient, after some time when we have properly sedated the patient, have given bolus dose of propofol and labetalol for hypertension, this patient develops hypotension. So my question is, which step is incorrect? Which step is not right? So can I get the answers? So my first option was stop labetalol, give RL bolus, start dopamine, and start noradrenaline. Which step do you think is incorrect? Can I get the answers? So my patient is having hypotension. Which step is incorrect? So I advised to stop labetalol. I advised to give RL bolus. I advised to start dopamine, and I advised to give noradrenaline. What do you think? Which one is incorrect? Which is not right? So don't take it as like one exam going situation. Take it like what you do at bedside. So any patient who is on antihypertensive and we are having hypotension, first advice will be to stop that medicine. So we'll stop labetalol. So any patient who is having hypotension in ICU, the reflex action is giving ringer lactate or any other fluid bolus. And after that, if even after that BP is still low, we start noradrenaline. So dopamine usually we don't give in ICU because of certain reasons. So the answer will be here dopamine 3. So some knowledge about vasopressors and inotropes. So when we think of increasing vascular tone in specific situations, then we use vasopressin. And when we think about increasing cardiac contractility, we use inotrope. The situations where we use vasopressors are sepsis, hypovolemia, and unexplained hypotension in ICU. And the examples are noradrenaline, dopamine, phenylephrine, which is preferred in OT, and adrenaline. And inotropes, when you find a poor cardiac function, poor left ventricle function, and the drugs of choice are dopamine, dobutamine, and adrenaline. You know, noradrenaline is mostly preferred in ICU, and dopamine is usually avoided because of arrhythmia. And we usually do a central line when you need a noradrenaline for long duration, or you need noradrenaline in very high dose, because this is irritant to the veins, and the dilution is usually done in 5% dextrose. So my next question is, so what is the role of salbutamol? We know that the patient is having bronchospasm. That's why we are giving nebulization, salbutamol. So my question is, what is not the side effect of salbutamol? So can I expect some answers here? What is not the side effect of salbutamol? You are giving salbutamol to one of your patient. So which one is least likely to develop? Tachycardia, hypokalemia, loss of PEEP, and hypertension. Can I see some answers? So you are giving salbutamol. Do you expect tachycardia? Yes. And hypokalemia, yes, because treatment of hyperkalemia is salbutamol. So if we give salbutamol, we can expect hypokalemia as a side effect. Loss of PEEP, yes, it can happen because you need to remove the HME filter and attach the nebulization circuit, and so there will be loss of PEEP. So you should not expect hypertension as a side effect of salbutamol. So you can expect tachycardia, you can expect hypokalemia, you can expect loss of PEEP, but hypertension is not an usual side effect of nebulization. So the use of nebulizations, there are different uses in ICU. One can use as bronchodilator in a condition like COPD or bronchial asthma. You can use nebulization as antibiotic and also as a part of treatment of hyperkalemia. So for bronchodilation, salbutamol and budesonide are preferable, and you know the side effects: tachycardia, loss of PEEP, hypokalemia, especially of salbutamol. As antibiotic, we use for colistin and tobramycin as nebulization, and the side effects will be environmental exposure if you don't take care of the delivery system. And some special tips: for COPD patient, we usually avoid using oxygen as a driving force, because COPD, if the patient have high oxygen, patient can develop carbon dioxide accumulation or carbon dioxide narcosis. And we should understand the nebulization delivery system, because presently there are different systems which are used in ICU, and there are different doses of for different indication. Like for bronchodilation, we use 0.63 microgram of salbutamol, but for hyperkalemia, we use 1.25 to 2.5 microgram of salbutamol. Now, our patient is also getting meropenem. We know meropenem is an antibiotic. But my question is, what is the duration of meropenem infusion? Is it 1 hour or 3 to 4 hours? May I expect some answers? This is very common drug, right? And presently, all of you know that we give meropenem over 3 to 4 hours. And there are certain reasons behind that I will discuss. Coming to antimicrobials, there are three groups of antimicrobials specially used in hospital or ICU: antibiotics, antiviral, and antifungal. Cefoperazone, piperacillin, meropenem, teicoplanin, these are common names among antibiotics. Oseltamivir, aciflovir are common names in antiviral, and fluconazole, amphotericin B, and casofungin are three different antifungals. So how to choose antibiotic? How do you prescribe antibiotic, or you decide that this is the best antibiotic for your patient? So first of all, we have to know the source. Suppose you are suspecting urinary tract infection and you are deciding between colistin and polymyxin B. These are almost like similar group of medicines, but we need to know that polymyxin does not concentrate in urine. So colistin will be better choice if you are prescribing for UTI. And which organism is more common in your ICU? It may be some gram negative or gram positive. Based on that, you have to prescribe your antibiotic. How is the chance of resistance? So one patient who is having immunocompromised condition coming repeatedly to ICU requiring multiple admissions, those patients will have high chance of developing resistance. So one simple single antibiotic may not help in this patient. And do you suspect atypical infection? So your patient has come with a pneumonia. You expect there will be a chest X-ray changes in one single lobe, but you find that there is bilateral chest X-ray changes. So maybe this patient is having atypical infection and you need to add something else apart from usual antibiotics. Finally, after some time, once culture reports are available, we need to decide whether we need to change anything. If the patient is having any organ failure, do we need to decrease the dose? You know that patients on dialysis or patients on CKD, they are prescribed lesser dose of antibiotic after initial 1 or 2 days. And every day you have to decide whether you need to change your route of the drug. Like linezolid is a very good drug which absorbs nicely if you give orally. Coming to duration of giving antibiotic, our last question was whether meropenem should be given over 1 hour or 3 to 4 hours. So this curve is the explanation. So there is a term called minimum inhibitory concentration. So above that concentration, bacteria is killed by antibiotic. So there are mainly two different types of antibiotic. One is concentration dependent. The higher concentration compared to the MIC that cause good killing of the bacteria. Amikacin is one of them. So if you give OD dose like once daily dose and MIC of the or concentration of amikacin goes high, that is very much effective. And another group is time dependent drug. That means as for example meropenem, the longer period it stays above MIC, it causes more effect. So we give like over 3 to 4 hours, and the concentration of the drug stays more than MIC for maximum duration of the day. That is the reason. Now coming to next question, same patient, lab investigation has come, and the only significant finding was potassium, which is towards lower side 2.7. So my next question is, which one is the example of high alert medicine? Pantoprazole, meropenem, KCL, ondansetron. Can I get some answers? 1, 2, 3, 4. Thank you. Thank you so much. So everybody is right. KCL is high alert. This is too simple a question because this is a daily practice of nursing staffs and daily classes. Which one is a high alert medicine? So the medicines are high alert because it, if given accidentally by any route or any dose, can cause harm to the patient. So these are the examples of high alert medicines like morphine, pethidine, fentanyl, propofol, thiopenton. Now coming to vasopressors and inotropes, dopamine, dobutamine, noradrenaline, GTN, and then there is a group of drugs named look-alike drug list. So these are of concern when you deal daily with medicines and patients. So these medicines are looking alike, and there is very high chance of accidental prescription of these medicines. Then there is sound alike medicines. So AKT3 and Accurate3, they are almost like same name for tuberculosis medicine, and you can clearly see that the concentrations are very much different. So you have to be concerned about that. Now your patient has developed bradycardia suddenly. What is the drug of choice for bradycardia? May I expect some answers? Isoprenaline, adrenaline, atropine, and metoprolol. Yeah, thank you so much again for the right answer. Atropine is the of choice medicine for bradycardia. So there are certain emergency drugs like atropine and adrenaline. You know, atropine is used for bradycardia and adrenaline for cardiac arrest. And I hope you have all done this course like BLS and ACLS, where we know where to use adrenaline. And atropine is not there in ACLS, BCLS protocol in cardiac anesthesia. But if you have bradycardia, then atropine is the first drug of choice if the patient is having symptom. So this is one open-ended question, no MCQ, but I expect some answers. TPN, total parenteral nutrition. Why do we give TPN central through central line? So we have two types of TPN, right? TPN central and TPN peri. So what is the reason behind giving TPN central through central line? What will happen if we give through peripheral line? So what is the reason? Any answer? Why we give central TPN through central line? Yeah. So thank you so much. I got the right answer because of high osmolarity. You can see in the last line that peripheral TPN is having an osmolarity of less than 900 milliosmol per liter, where central TPN is having an osmolarity of 1500. So anything around or less than 1000 milliosmol we can give through peripheral line, but more than that we should use a central line for transfusing, right? And this is my last question. So many time you can see this type of prescriptions, especially in a patient who is having a respiratory tract infection, suspected fungal infection or COVID, and patient is having delirium. So patient is on meropenem, voriconazole, ondansetron, azithromycin, quetiapine, and what drug interaction you are expecting. So whenever you are going through drug charts, you have also need to look at the possible interactions or side effects if you are prescribing multiple drugs. So I feel this is important for all of you. So you are prescribing meropenem, voriconazole, ondansetron, azithromycin, and quetiapine. What drug interaction are you expecting? May I expect some answers like which one? 1, 2, 3, 4. Convulsion, renal failure, dry cough, and arrhythmia. Which one? I hope many of you see this type of prescription. It is not very uncommon. Out of 10, at least one prescription you will get like this. So if you remove meropenem from this list, and if you remember your psychologist, psychiatrist who is prescribing quetiapine, you will remember that each time the psychiatrist will request for one ECG. So they want to see the QT interval, the starting from Q to end of T in ECG, because quetiapine can QT prolongation. And you need to know that all of these drugs apart from meropenem can cause QT prolongation: voriconazole, ondansetron, azithromycin, and quetiapine. So if you have prolongation of QT, then that patient may land up in ventricular tachycardia or ventricular fibrillation. So arrhythmia is the answer here. Right. Thank you so much. And take home message for from today's class. I will give one example which I have heard of. I have not seen about this patient. So there was a telephonic advice for giving diclofenac 75 to one patient who was under palliative care for pain management, but accidentally somebody heard that it's baclofen, diclofenac, baclofen, and given baclofen 75 milligram. The patient had severe respiratory depression, required immediate intubation, and put on ventilator. Luckily, the patient came out of the ventilator after 48 hours of mechanical ventilation. But that is the reason we need to be aware about the drugs we are giving to the patient, because this is a serious safety concern. Thank you so much.
Hello.
Hello.
Thank you, Dr. Pralay, for a nice presentation. If we have any
Thank you.
question, can you please unmute and ask for that? Hello. Anyone has any question, want to please unmute yourself and ask Dr. Pralay.
Yeah. So we can get that questions in the chat box. Can we get any questions in the chat box? I hope you understand that in most of the situations we give medicines without knowing the details. Not all of you, I expect that most of you do that, but at least I expect that if you are giving one medicine, you need to know about the details of the medicine, because a small mistake of dose, a small mistake of color of this medicine or name can cause a significant damage to the patient, and those things can easily be avoided if you understand the details of that medicine and the side effects. It becomes easier for you to monitor the patients also. Do you have any questions? I cannot see any questions in the chat box, so I hope that everybody will go back and will read about their respective drugs now. Thank you
Okay,
so much.
I don't have any question. I think we can conclude the session. Thank
Yeah,
you, Dr. Pralay, for a nice
thank you.
presentation.
Thank you so much.
And I think we can end the session here.
Thank you.